Alrighty, good afternoon, everyone. Thanks for being on here. I'm going to give folks another couple moments to get settled and then we'll get started. Alrighty. Good afternoon, everyone. Welcome to the Words Matter Outcomes Change training offered through the McLean County ROSC, which is Recovery Oriented Systems of Care and Faces and Voices of Recovery. We're so grateful that you can join us today, and we're very excited to welcome our presenter, who is Teresa Noor. Teresa is a veteran clinician, educator, and a leading voice in the New York recovery landscape. With over 30 years of experience in the addiction recovery field, her career is defined by a landmark tenure as the Senior Director of Recovery Education for Friends of Recovery, where she co-founded the Best Practice Trainer program. She is a certified addiction recovery coach professional, facilitator, a registered trainer with the New York Certification Board, and a New York State OASAS education and training provider. Notably, she served as a subject matter expert for the development of the Peer Supervision Professional certification in 2023 and had chaired the NYS Recovery Conference Planning Committee since 2016. Teresa holds a bachelor's in psychology from University of Albany and completed specialized Tai Chi and holistic medicine training at the Green Mountain Institute in 2000. Her professional background includes decades of service as a counselor, clinical supervisor, and program director. Today, she focuses on training, emphasizing evidence-informed curricula, staff wellness, and the integration of mind-body practices. Teresa, thank you so much for being here. We'll go ahead and turn it over to you.
Thank you so much, Carrie. I appreciate the invitation. I'm very excited to be here. I really enjoyed putting together this curriculum for you all today, and I'm going to kind of repeat my utterance as I came into a webinar because I have never really liked webinars. I say that I would rather put an ice pick in my eyeball than be in a webinar because sometimes just having somebody talking at you and seeing the little words on the screen, I don't always get as much out of it. So I want to try to encourage. I see that we have 17 participants right now, and I know that includes us three. So 14 folks in the room, and I'm going to try to ask you to be, I am going to ask you to be interactive today because adult learning style is really that the way that our brains work is that we have to speak things, we have to write things, we have to interact with each other to remember the information that's coming at you today. So I will also say that I am PowerPoint dependent. So I am going to share my screen and present to you, but I also want to ask for participation because there is information in this webinar that was well researched, but really the lived experience that you all bring is really going to be a bigger part of the learning today. So I'm hoping that y'all will chime in, and Kat and Carrie are going to help me out with the chat because I may not be able to see everything as it comes in. So I am going to ask you to do that. But right now I'm going to share my screen and just take it from the top. So it is Words Matter, Outcomes Change, Evidence-Based Stigma Reduction for Co-Occurring Disorders. And this presentation is brought to you by Faces and Voices of Recovery, which I will tell you a little bit more about. Let me just make sure my screen is working here. Yep. And you already saw my bio. But Faces and Voices is the National Recovery Community Organization. Our mission is changing the way addiction and recovery are understood and embraced through advocacy, education, and leadership. The vision is that we envision a world where the diverse voices of individuals and families affected by addiction are embraced and connected in communities, free from discrimination and injustice. So that's actually an expanded vision statement. Faces and Voices has been around for a long time and has gone through some revision. making sure that everyone feels included. So the first thing I want to talk about is who governs Faces and Voices is the recovery community. So you tell me if you want to throw in the slide, who in the chat, who do you think, who's the recovery community? So we have answers on the slide, but if you want to throw who you think that is, and basically to tell you that it's all of you. So we say people in recovery from addiction, their family members, friends, and allies. So I'm assuming that everyone in the room is one of those things. You may either be a person in recovery yourself, you may be a family member. Yep, everyone, all of us, thank you so much for chiming in. We're all part of this recovery community. And I also want to lead with some hope here. So the recovery movement, and especially Faces and Voices, is really helping people to share their stories in non-stigmatizing ways, to let others know that they're not alone and that recovery is possible. So really sharing that lived experience. And actually, we'll see in the slides today that sharing a lived experience is one of the most powerful ways to combat stigma. So we will talk more about that. This is maybe some review for some of you, but we also want to just mention, that there is no one-size-fits-all pathway of recovery, that we really want to honor multiple pathways of recovery. And there's actually a whole training called Multiple Pathways of Recovery if you ever want to learn about the myriad of ways that people get into and sustain and maintain their recovery from both mental health issues and substance use disorder. But we know that it's often a combination and sequences of multiple pathways over time, that people aren't always just, coming in with one pathway and sticking with that same one for the rest of their lives. And we also want to make sure that it's culturally and individually contextual, that people's pathways are sensitive to where they come from and who they are. Okay, so if you have any comments or questions about any of that, feel free. I am able to see what's happening in the chat, so I would love to hear any opinions or thoughts, feelings you have about any of what I just said already. And then I will move on to tell you what the agenda is for the day. So this is the agenda. We're going to do this overview and introductions. I'm going to just give you some of the current data around substance use disorder and mental health and recovery, and we'll define stigmas as kind of as a level set. And then we're going to talk about the effects of this double stigma. But really the bulk of what I want to talk about today is providing hope. What can we do? How can we combat stigma? And then at the end, I'll do a little summary and a call to action, because training doesn't, go anywhere unless it makes a difference in our behavior. So I'm going to ask you just to be thinking about throughout the presentation, what can you do? As a result of the information that you are receiving today, of some of the things you may learn from each other, what are some of the things that you are willing to commit to do to be part of the solution? Okay. And so, of course, we have our learning objectives at the end of the participation of the webinar. Participants will be able to analyze the current research and data on stigma related to substance use disorder and mental health, explain how stigma affects both community support systems and individual recovery outcomes, and then apply, my most important one, is evidence-based strategies to help individuals address and overcome stigma or self-stigma and community stigma. And then the end is to identify and commit to specific actions within your personal and professional roles to reduce stigma and promote recovery-oriented practices. So that's just the overview. Now I want to know who's in the room. So I'm going to ask you, as much as you're comfortable with, to throw in the chat who you are. You can use your pronouns if you choose to, what organization that you work for and the role that you have. And then this is completely optional. If you choose to identify yourself and your relationship to recovery. So whether it's you yourself that's in recovery, you're a family member in recovery, or you're a friend or ally of the recovery movement. Tell me a little bit about your motivation for attending this training. I mean, a couple words. You don't have to get crazy about that. And then just to be here and to embody where you are in the moment, to feel your butt in the chair, so to speak, is one word for how it feels to be accepted for who you are. Because really, that is kind of the goal of reducing stigma, is so that people feel accepted for who they are, for all of who they are in their multiplicity. So I'm looking at the chat and I'm hoping that people are feeling comfortable enough. You don't have to do all of them. Just throw in whatever you feel comfortable with that's on this introduction slide. And I'm going to give that a couple of, like 30 seconds to a minute so I can drink water while you're writing in the chat. And Kat and Carrie, if you want to prompt people, feel free.
Absolutely. I was also going to say at any point, if anyone would rather talk out loud, they're welcome to raise their hand on the Zoom feature and I can allow you to speak as well. So we see a couple different things coming through in the chat. So thank you all for your engagement.
Yay, we've got interns. I love interns. I've hired interns. Interns make the best employees. Okay, Home Sweet Home Ministries, excellent. Yes, please, supporting your neighbors who are in recovery as best I can. I love the use of that terminology, our neighbors. That feels very inclusive to me. Rural health, yes. I'm in rural New York, so we're a friend. Okay. Well, thank you so much for folks that are chiming in. I will read through most of these probably later this afternoon, but okay, you've got a lot of different agencies here, and that's really, it's so important to have these coalitions. So I'm very appreciative that we're able to gather. And we have some folks with some lived experience. Thank you so much. And I appreciate it when we get to different slides. I am going to be asking folks with lived experience to really talk a little bit about their experience. And as Carrie said, you can be unmuted, so we can actually have people hear what you have to say in your own words. So I know sometimes it's a lot to type. Yes, definitely. And then strength is a word. I love that. When we feel accepted for who we are, we feel strong. That's beautiful. Okay. So I would encourage you all as well to take a look at, what folks are writing in the chat. This is really, it's important for all of us to feel comfortable and safe in this kind of webinar. And this is one way of doing that, is getting to know each other, who's in the room. So I appreciate that. All right. So I'm going to just move on to a quick level set of the current data and a definition of stigma. So this lovely little chart is showing us here, just taking a look at the current data on the prevalence of substance use disorder and mental health issues. And this is all coming from SAMHSA's release of the 2024 National Survey on Drug Use and Health. This is all self-reported information. This was just published in 2025 and 2026. So just looking at the numbers here, I'm not going to read them all to you from the screen, but we've got a pretty fairly large percentage of folks who have either struggled with a mental health issue or a problem with drugs or alcohol, and then 8.1% of our of the people who reported had these co-occurring disorders. So I'm going to just read you a little bit more about that. So it was actually 8.1% of the general population. So 1.2 million people in our country have reported having issues with both the mental health issue and the use of alcohol or other drugs. So that's just some look at the prevalence. And then I'm going to click on to the next one and talk a little bit about what these numbers actually mean. So this intersection of substance use disorder and a mental health issue is fairly common. It breaks down to roughly 1 in 12 adults. That's a pretty significant number. 1 in 12 adults has a dual diagnosis. So the way that breaks down is 1/3 of those with mental health have a substance use disorder. Almost half of those with a severe mental health issue have a substance use disorder. And then nearly half of those with a substance use disorder also live with a mental health issue. So this is all, self-reported. But we want to take this a little bit of a closer look at that first slide, and I just broke out and bolded the recovery data. This is really interesting to me. So even though we have these fairly significant percentages of the population who have reported these issues, more than half in all cases, 66%, 74%, and 65%, have reported that they either are in recovery or have recovered, is the way that it was reported on this survey. So 66.9% of the people reported that they were in mental health recovery or recovered. 74.3% in alcohol or other drug recovery or recovered. And roughly, so it was estimation between 15 to 17 million people, so roughly 65% reported that they're in recovery or recovered from both. So we always want to lead with hope, basically. So the takeaway on that for me was we do recover. So actually, recovery is the expectation, not the exception. And that's not just a hopeful statement. That's according to the data. That's according to the numbers. So I just want to read another thing to you. Much of what we need to do to reduce the stigma for dual disorders is to provide that hope, right? To the people living with these conditions, to their families, their friends, the general public, and maybe more importantly, to the people who provide services to them. And so we're going to talk a little bit more about that as we move through. Feel free, like I said, I can see the chat in the webinar chat. So if you have questions or you have comments or you want to stop me at any time, feel free to do so. I don't want to just blow through this and talk at you. Okay, so what is stigma? You tell me, what do you think stigma is? You have your own definitions of stigma. And what does providing hope look like? Oh, God, that's such a great question, David. Yeah, I am going to give you a few examples of that. I have some slides on that, and we were definitely going to talk about what that looks like. But mostly, the short answer is lived experience. People who are in mental health and substance use disorder recovery provide hope just by speaking out and saying that it's possible to be in recovery. So that's certainly one of the ways that will provide hope. Yes, so stigma, when people think negatively about something and they don't have close experience with it. Yeah, so there's a lot of folks out there in the world who have concepts and beliefs and theories about what addiction is or what a mental health issue is, and that affects their behavior. So yes, you've got that correct. Negative attitude or belief towards someone who might be struggling. Yes, correct. All right, so I'm going to talk about, excuse me, what Western Australia Department of Health has a lovely little definition here that we'll use. Stigma is a mark of disgrace that sets a person apart from others. When a person is labeled by their illness, they are no longer seen as an individual, but as part of a stereotyped group. So this is a way that we look at stigma. And yes, I would say they feel shame too, unfortunately. Yes, and we're going to talk about that as well. So What the research shows is that stigma is really broken down into these three core interacting components, and we call that the triad of stigma. And basically, it translates into how we think, how we feel, and therefore how we act. So, the first part is the thinking part. So, this happens in the mind. This is our stereotypes, these are our attitudes. And basically, this is socially held generalized beliefs, and they are inherently dangerous and weak or incompetent. The thought pattern is that people with substance use disorder, although the stereotypes and attitudes are inherently dangerous, this is an example, is that people who have a substance use disorder or people who are who have a mental health issue are inherently dangerous. Maybe they're weak, maybe they're incompetent. The way that it manifests in the heart, in our feelings, is as prejudices and beliefs. So this is a negative emotional reaction or an evaluative bias. So we may have fear, we may feel pity, we may even have a resentment against people with dual disorders or substance use disorder or a mental health issue. But then how all that translates is into discriminatory behavior. That's how we end up acting in our policy making, in sometimes in our programs even. And so these are the actions and behavioral exclusions, keeping people out because they have these diagnoses. And that can look like social distancing, hiring biases, or institutional neglect. And we'll talk more about that in a few slides. Okay, so now comes the part where we have to make sure that we can make the, yes, can we make the video work without losing you guys? All right, so I'm going to show you a little video. This is from British Columbia, from a company called Northern Health. And I want to share this with you. This is some lived experience of how people with co-occurring disorders or substance use disorder or mental health experience stigma. So I'm going to see if this will play for you here. I might actually have to come off share and share my YouTube video because sometimes I can make it work, sometimes I can't. All right, that looks like I can't because it's not playing from here. All right, I'm going to come back and share another screen and play the video. All right, I believe, now let me know if you can hear it okay.
A lot of us struggle really hard. I just would like actually just to be heard or to get to know me. Or say you don't want to know me, that's fine, but don't look down upon me. You don't even know me.
Things that make me happy, not being discriminated. I just like being safe. Be really nice to have a place to go, place to live.
I feel judged like going into businesses or stores, you know, because I'm Native, they will follow me in the store. They automatically think that I'm going to steal, you know, just because of my color or my race. And because of the track marks on my arm, they automatically know that I'm an addict. So they think that I'm in there to steal, to support my habit. Yeah, I get that quite a lot wherever I go because of my appearance, I guess. It hurts. It hurts a lot.
Most of the time I feel like as an outcast, like black sheep,
Like, doesn't matter where I go. If I get clean stuff, I can't find a happy place where I fit in because I'm always looked at different. You know, I go into shopping centers, stuff like that. I get followed around. I'm kicked out of just about every store in town. Yeah, I get judged because I don't know why. I don't know why people judge me that way.
It was a horrible feeling, the way they made me feel. It made me feel like I was a germ. Yeah, I will never go back there again.
So I have a hard time going to the hospital now when I'm sick. Being looked and judged by somebody that's supposed to care for you and help you, it's really, really hard on a person.
The impact on me and anybody who uses illicit substances is that you're categorized into this, that you're identified then by your drug use or your drug of choice, not as a human being or who you are.
Just treat me like human, instead of just judging me by my appearance.
You'd be surprised, just talk to somebody on the street. If you see them and you think they're addicted or have them, don't shun them away. You'd be surprised who they were or what they did before. It could be anybody. I'm just as human as everybody else.
Okay. So, I'm not going to go back to the PowerPoint because I want to get some reactions yeah, I like what Amber said. That part really hit you. And it was an active addiction. I was treated horribly by medical professionals. Yeah, that. Oops, wait. Let me get that off of here. Sorry about that. So that was the part I think that hit me the most as well when I watched this for the first time, was that, people were talking about being in stores and, in the general population, but to be treated with disrespect and to feel the effects of stigma when you're in a treatment facility or you're in the medical facility. And I've personal experience with this in as a professional and also as a family member of someone who actually passed away from substance use disorder. But when he was in his active addiction and we would go to the hospital, we would experience that. Was treated horribly in the emergency room, looked at as drug-seeking behavior, and the stigma was real, even in the places where you would think that people would be treated better. So I would love to hear if there's anyone else that, has experience with that, or, how did that video land for you? How did that make you feel? Yes, people should be treated equally. We are all human beings at the end of the day. That is correct. Okay. Okay. Yeah. Yeah, that part, that, being native, that made me feel even more sad. Yeah, thank you for that, Amber. Yeah. It's a YouTube video, so feel free. I can certainly send you the link to these things if it's something that you might find useful in your setting to show to folks. It's a popular video at Faces and Voices of Recovery. So, and I have another one that I'm going to show you in this presentation as well. Yes, a lot of fear and uncomfortability to be around people who struggle. That's true. people don't always know what to say, don't know how to act, and so yeah, a lot of fear and discomfort around that. Yes, and our world does need to be more empathetic of others. Okay. All right, I'm going to go back to the PowerPoint. So let's talk a little bit about, oh, am I sharing? Not yet. I got to share screen. That would help. I'm pulling it up. I can see it. You can't. Okay, so let's share the screen and talk about how the stigma is actually different, which is interesting. That there's stigma attached to both mental health disorders and substance use disorder, but there are some subtle differences here. So the public holds significantly more stigmatized views towards individuals with SUD than towards those with other mental health conditions. Why? Why do you think that is? What? Because there's research out there that shows. Yes, you want to talk about that, Amber? You got your hand raised.
Amber, you should be able to speak now.
Yeah, I think people just are scared that they're criminals or something. Like, I think because they're using an illegal substance and that they're going to be more dangerous than someone that maybe just has a mental health issue.
Interesting. Yeah, that I'm sure that definitely contributes in. Yep. Anybody else got any other ideas about why people with SUD are more stigmatized?
Teresa, there's a couple things in the chat. Samantha said people think it's a choice, whereas
Yes.
we
Yeah,
also have Desiree said people fear what they don't understand. And Elizabeth
correct.
Thomas said people look at substance use disorder as a choice, whereas mental health is not.
That is what the research is showing. So the driving factor behind the disparity is the attribution of personal control and responsibility, which is interesting because we've had decades of public education and it has shifted around mental illnesses, especially like depression and schizophrenia, where we're talking about it being, it's a medicalized neurobiological framework. But that shift is really stalled for addiction, even though we have, this brain disease model. And I don't, people have, there's one of Faces and Voices of Recovery does a training called The Science of Addiction and Recovery. And this was many years ago that it really was predicated on the brain disease model. And some of the research is showing that actually has kind of backfired a little bit. That when we attribute behaviors to biological causes, now you're really messed up. Not only do we first of all, we see that you caused this, that you're within your personal control, you could have stopped it, and your responsibility. But then if we use the brain disease model, it's like, oh, well, now your brain is affected. Well, now you're really scary and dangerous. So it hasn't always helped. So I don't know if anyone has any thoughts or feelings about any of that, but this increased public perception that individuals are unpredictable and fundamentally different now has not always helped the case of trying to destigmatize either of these illnesses. Okay, that's about all I want to say about that. So let's move on a little bit. I really appreciate Carrie, you chime in with stuff in the chat because that if you see anything, certainly bring it to my attention. Okay, so we're going to move on to the effects of stigma, just to take a look at how there's this real world impact and on the burden of discrimination. So there is an organization called SANE, which I thought was an acronym, but it isn't actually, in Australia. But they are the leading national mental health and charity, and they do research. They are renowned internationally for pioneering work on behavioral health stigma And they released something called the National Stigma Report Card. And that was something that was conducted in partnership with the University of Melbourne in 2025. So this was a survey that they put out there. And what they concluded was that the impact of public and structural stigma often surpasses the clinical severity of the condition itself, which I thought was really interesting. And you can see that in the clip, that people were talking about how shameful they felt and how sad they were, and just the effects on their mental health. The stress that stigma causes is sometimes perceived as worse than the clinical severity of the condition itself. So it was 67.7% of the survey participants agreed that the stigma and discrimination they faced was worse than the mental health problem. Really interesting. So discrimination, so the stigma not only affects how a person feels about them, but it also affects how they are treated. And so that leads to discrimination. So discrimination can happen in many different areas of life. So in social and family life. So culturally, the most frequent environment for stigma predominantly manifest as friends, partners, family members that are lacking this understanding of the condition's operational impact. And then we have in the employment and in the workplace. And this holds also one of the highest structural burdens. So it results in systemic barriers to finding or keeping a job, underemployment, fear of disclosure due to professional retaliation. And there's all kinds of ways that discrimination happens in the workplace. And then in housing and social services, severe structural stigma blocking access to equitable renting opportunities, public housing options, the acquisition of social services in and of themselves, or any other disability benefits. People are often blocked in accessing those things because of the stigma associated with SUD and mental health. And then, of course, the one that bugs me the most is in healthcare settings. So devaluation by medical providers, diagnostic overshadowing, which we'll talk about a little bit later. That idea of attributing their physical ailments entirely to a mental health or substance use disorder without maybe taking into consideration that they might actually have a physical problem. And then, of course, the isolated care environments, like we'll talk about the silos and how that really doesn't help people get the treatment that they need. So that's, the bottom line is stigma prevents people from seeking help and or receiving quality care. They may receive care, but it may not be exactly what they need. Okay. Any comments or questions about any of that? Okay. So we'll talk now about the effects of double stigma. So all the stuff that we were talking about was just stigma in general and as it related to one side or the other. But when you have both disorders, we have what we call double trouble, right? And so this can diminish the individual's recovery outcomes. So first of all, that internalized stigma creates this barrier of shame. And how that manifests is often that people are hiding their symptoms from themselves, from family members, from providers, because they're ashamed of it because of the stigma. And then that may lead to them delaying the seeking of care. And it may cause people to drop out of treatment because they're in one or the other. So someone in SUD treatment might be having mental health symptoms and they don't want to talk about it, so they leave. Or it may be the other way around. Somebody's in mental health treatment and they experience a substance use issue and they can't be treated there. They're stigmatized and they may leave. And of course, that all leads to an increased misuse of substances. And then the other thing that we will find with this internalized stigma is that we see folks in higher rates of crisis. You may find people who are homeless, have suicidality, there's overdose, there's involvement in the criminal justice system. We see these higher rates of crisis happening with people who have both disorders. Okay, and that's all from NIDA, National Institute on Drug Abuse, which I wish they changed their name, but that's another whole story. Okay, the other thing that happens is that it puts people in this double bind, that there are actually these barriers to care in the provider system. And what that looks like is, we've got some statistics on that. So out of the folks that reported that they had SUD or mental health, only 41%, 41% received neither. 41.2% received neither treatment for SUD or mental health. 41% had only mental health treatment, and very small, only 3.2% received SUD treatment. The folks that got it right is still a really small percentage. So only 14.5% received both concurrently, mental health and SUD treatment. And that's because our systems are fragmented, and often there's this exclusionary criteria. I'm probably not telling you guys anything you don't already know. You probably experienced this trying to get someone into treatment. So you try to, the mental health providers say, we don't take people with substance use disorder, they're too unstable. Or, they're not being compliant because we're asking them to be abstinent in this program, and they're not able to. And so they may not understand a harm reduction lens. And so mental health providers will exclude people from treatment because they're too unstable or they're non-compliant. Where SUD providers see people who have a severe mental health issue as being too complicated. You're too complicated for our thing. And what that basically means is that they lack the psychiatric staff or mental health training, or they lack resources to even manage the severe mental health issues. And so what that looks like, as I click to the next slide, is this ping pong effect. So you have the patient in crisis. You got the mental health clinic saying, we can't treat your depression until you got 30 days sober. Ping, I'll send you back to the addiction rehab center, who says, no, we can't treat you here because you have psychosis or trauma, and we can't until you're fully detoxed and your mental health is stable. And so we ping you back to the mental health clinic, and then the mental health clinic pings you back. And so I've literally seen this play out in real time because systems are not able to treat the whole person. And then another piece is what we call the doubly blind and doubly unkind, where the person is judged and not fully seen for who they are. And this is what I was saying before about the diagnostic overshadowing. So in substance use disorder settings, the symptoms are attributed to addiction, and maybe they're ignoring any underlying mental health crisis or issue. And then in the mental health system, all of the symptoms are attributed to mental illness, and they're missing the signs of a substance use disorder because they're not trained to recognize it. So that's why I've got the hammer and the nail thing. It's like when all you have is a hammer, everything looks like a nail. So we really need to be cross-training our staff and making sure that they're able to recognize both disorders, whether it's substance use or mental health, and be more savvy to how they interact. How is this going in your settings? I'm wondering as I'm saying these things, because it sounds like you guys might be a little more integrated in Illinois than we are in New York. In New York, we still have two state agencies, the Office of Mental Health and the Office of Addiction Services and Supports. And they talk to each other, but our systems are really not integrated. We do have some programs that are duly licensed, but those are few and far between. So tell me about Illinois. Are your systems still in those silos, or are you a little more integrated over there? Anybody know? Yes, you think you're more integrated. There are still some silos. Okay. All right. Thank you. I appreciate the feedback there. Oh, at Heritage, you're very much integrated. It's like, go Heritage. Yay. Thank you, David. That's good. Illinois Department of Human Service Division of Behavioral Health and Recovery. Okay. There is effort and there is hope. Oh, that's so good. I'm so glad to hear that. Yes, diagnostic overshadowing with human trafficking victims. Wow. Yeah. That's interesting. I worked with young women who were trafficked at one point, and it was a very specific program in Arizona, not in New York. So yeah. Okay. Let's move on to what we call the reoccurrence trap. This is just bang how it happens, right? Because one condition is frequently ignored while the other is treated, the untreated condition inevitably triggers a reoccurrence in the other. And then that reinforces the stigma and the stereotypes. See, they just don't want it, or they're not stable enough, or whatever we're saying. And then the individual is seen as untreatable or refusing to get better. So that's kind of known as the reoccurrence trap. So you can see often how people are viewed will make a difference in how they are treated. I've seen this I've worked in substance use disorder treatment for most of my career, but I've seen, in the staff room when staff were complaining about a particular client or resident. I was in a residential program for many years, that no one would bring up, that maybe there was a mental health issue that we were overlooking. It was usually this, oh, they don't want it bad enough, or, they're just drug seeking. There were so many negative perceptions around people that could have been helped, but and oftentimes ended up leaving the facility because it wasn't fully integrated. Okay, so in terms of community support, there is also this double blind. So rejection across both recovery networks, so our social networks, often leave the duly diagnosed individual without a complete sense of belonging. I mean, unless you're in a double trouble meeting, which is, a mutual aid meeting that someone is really recognized for both. And then, so what we often see in the mental health community is that people using substances, they're seen as uncompliant or unstable. And then we have in the recovery community, the symptoms often are seen, the mental illness or taking medication are seen as, you're not really completely sober if you're taking medications, or often the mental illness symptoms are even overlooked. So I don't know if you have double trouble meetings or places where it's more integrated and folks are not still in those silos, even in the recovery community. So maybe tell me a little bit more about what's happening in Illinois with the recovery community. Do you have those integrated mutual aid meetings? Whoops. Gonna minimize the chat here. Okay, they're still pretty separate. Okay. Have you heard of double trouble? I mean, that's one of the things, or dual diagnosis meetings. Okay. So maybe that's one of the solutions, is to get one of those meetings started. Okay. I sometimes feel like in New York, the recovery community is light years ahead of our systems, and in other states, our systems are ahead of our mutual aid settings. So, but you do interact in the living room, yes. Okay, good. Okay. We also have to take into consideration when we're talking about stigma these compounding social determinants. Making sure that we understand that it's not just the double stigma of SUD and a mental health issue, but if someone has any marginalized identity, when you add those two things together, you are really increasing the social distance that is enforced by the community or the public. So you've got just the double stigma blocking access to whatever vital life opportunities. And then if you add in things like race, gender, poverty, history of incarceration, et cetera, that will potentiate, and certainly that is going to block the access, exponentially to all kinds of life opportunities. So keeping that in mind as well. All right, so that was the problem. Let's get to the solution. We're halfway through the slides, and we are going to talk about providing hope. How am I doing on time here, Carrie? We're 20 minutes in, and we have 90 total.
Yep. So you have like another 40 minutes to go.
Okay, so good, because that means I don't have to just blow through things. We can have a lot of interaction. Okay, excellent. So what can we do? So here are some evidence-based solutions. So to deconstruct stigma, what the current research recommends are three things. One is universal integrated care. So we've already been talking about that, breaking down the silos, getting people to have, whether it's in the mutual aid meetings or whether it's in our, in the places where we provide treatment, whether that's in the hospital settings or clinics, universal integrated treatment. The next thing is person-first language. And so Faces and Voices of Recovery has a whole training on non-stigmatizing language, on how to tell your own personal recovery story, whether that's you as a person in recovery yourself, or as a family member in recovery, or an ally to the recovery community. How do we tell our stories using person-first language? And my favorite is contact-based interventions, sharing lived experience. So we'll talk more about all of those. So first, the contact-based interventions. So the most effective way to reduce public and institutional double stigma is structured contact-based programs. So what we're asking you to do is to facilitate direct engagement between clinicians, students, community members, individuals who are successfully living in long-term recovery with a dual diagnosis. That's what you do. I love that. And David, I would also ask, that is what you do when you are in the living room and you're sharing with each other. I'm also advocating that we have people with lived experience share that lived experience with policymakers, with executive directors, with clinic staff, with people who may not be directly exposed to both. So I'm loving that you guys do that for each other. But yes, let's teach up a little bit too. So hearing authentic stories of complex intersectional recovery breaks down the biogenic and moral stereotypes that the dry data is not going to change. So, we looked at the numbers, but really when we saw the video, that's for me what makes more impact than the numbers. Okay. Oh, nice. Oxford houses. Oh, I love it. That's great, Amber. Have you guys seen The Anonymous People? That's one of my favorite movies, not so much on the dual diagnosis side, but for addiction recovery. That is such a beautiful advocacy movie. That was really, I kind of changed sides from working in the addiction treatment industry to working on the recovery side after I saw The Anonymous People. Okay, so how we can do this in organizations. Yes, please look that up. So in organizations, I'm gonna share another video about changing the way we speak, because we can all choose to use recovery-oriented person-first language. And I don't think I can make it. Oh, I can't make it work from there, so I will have to come off share and share my other screen. But this is a really excellent video. Bear with me for a second. Share screen with the sound optimized would be good. Okay. Let me know if you can't hear it.
Recovery language is the language we hope that everyone will use one day. Because recovery language is about more than just behavioral health. Recovery language is about creating an environment that allows all of us to be fully recognized as people. When we talk about recovery language, frequently what comes up is that it's language that puts the human and the person before the diagnosis or the label of any kind. Oftentimes, when we see people referring to politically correct language, they're talking about something that's being forced upon them. The reality about recovery language is that it's something that we can all choose to use. One of the things that I frequently tell people when I'm discussing recovery language with them is to think about it this way. If I choose to use a particular word, derogatory or demeaning, regardless of my intention in using that word, it's going to start to frame the way I think about the people or the things to whom I ascribe that word. But if I make the conscious choice not to use that language, slowly it's going to start to alter the way that I think about things. Because the words that we use frame the thoughts that we have. And our thoughts and our thinking, that's what creates the way that we act. And how we act, that's how we are in the world. That's the world that we create around ourselves. So when we choose to use recovery language, person-centered, hope-filled, non-stigmatizing, we are changing our own way of thinking and, hopefully, bit by bit, changing the world that surrounds us.
Okay. Thoughts, feelings, reactions to that. I like that video because it really does focus on the thought processes. And we have to really recognize how powerful that is, that how we think about people and even how we think about ourselves has an effect on our behavior. And I always tell this story when I show that video. I read this book called Mindful Loving, which was a marriage and family, trying to help relationship book. And it was written by a marriage and family counselor who said that marriage and family counseling doesn't work because people come into the experience with the agenda of changing the other person, not about changing themselves. And he studied with some guru, I don't remember who, Sai Baba or somebody, who taught him about monitoring thoughts. And so he's created this whole way of working with couples where you didn't have to work with couples. You worked with one of the people and coached them to change the way they were thinking about their partner, and then watched the relationships change. So if they came into the session with he's a this or she's a that or they're a this and like always pointing outside, it did nothing. But when he was when people started to change the way that they were thinking about their partners, they actually changed their relationships. And there's a study that he quotes in that book that was done at a high school, or I think it was a middle school actually, where there was a little girl who was the bad kid, right? All of the teachers hated her, and they would talk about her in the break room, and she was always in detention. She was always after school. She was always in this principal's office, just in trouble all the freaking time. And he went in and worked with them, not the little girl, to change the way they spoke about her in the break room, in the lunchroom, and to change the way they thought about her, that maybe she had some issues at home, or maybe she was dealing with, who knows what she was dealing with. But he coached the staff for 6 months to not speak a word of negative criticism about this little girl, and to change the way they were thinking about her. And lo and behold, it worked. The little girl was no longer in detention, no longer in the principal's office, no longer acting out, and they didn't even talk to her. This was not working with this child, it was working with the staff. So I loved this example because it's really speaks powerfully to how we perceive the world is how it is. Yes, change your words, change your thoughts, and change your thoughts, change your behavior. Change your behavior, change the world. And so that's why I really like that video. Once again, if you would like the links to these, I'm happy to send them to you. Just a really powerful video on using person first name language. Any other thoughts or feelings or comments about the video? Okay. All right, let me go back to Mr. PowerPoint here. Okay, it would help if I shared the screen. There we go. Okay, so we'll move on from that. So this is just a little chart that we put together to just give a couple of suggestions on non-stigmatizing language and how you can actually change. So looking at the left side is the stigmatizing term. So what, the instruction at the top is to demoralize language, take the morality out of it. So when we call somebody an addict or a junkie, that has a huge stigma attached to it. Now, I will say, when we do this larger training, we do talk about the places where it's perfectly fine to use the word addict. Like if you're in your mutual aid meeting and you want to call yourself an addict and everybody in the room knows what you're talking about, have at it. I do this. I have a mutual aid meeting, and if I want to identify myself as an addict, I will, because they know what I'm talking about. Heads are bobbing up and down and we're relating. But if I'm standing in front of a lawmaker and I'm trying to get a program funded, I may not want to use that terminology because what it conjures up in their mind, just think about it. When you see anything on television, on the news, or about addiction, what are the actual images that they throw up on the screen? What are the things that you see? You see needles, you see graffiti, somebody living under a bridge, you see somebody who's dirty or disheveled. We don't ever see the full picture of what addiction looks like. We only see the highly stigmatized version of it. And so when we use that word, that's what people think of. And also, like the term dirty, if we're talking about drug screens. Never do you walk into your doctor's office and you have a high, A1C for, diabetes. Does they say you're dirty for sugar? They say you have a high A1C. So we want to say that somebody, tested positive for a substance or they returned to active use. We don't want to say that they're dirty. Labeling people as non-compliant or manipulative. That's definitely bopping it back to they don't want it bad enough, or, somehow, making them the villain. And maybe what we want to say is that they're experiencing a barrier to treatment or to alignment with treatment. Dirty for sugar. Yes, no, I know it's funny. And clean, right? What's the opposite of clean is dirty. So once again, if you're in your mutual aid meeting, you want to use the word clean, have at it. That's fine. But in the general public, when we use these words, we want to move more to what they call the evidence-based alternatives, or person-centered. This is a person who is in active recovery or in sustained remission. So, using the more medicalized language or recovery language. Does that make sense to people? Are we good with that? And like I said, there is a whole training that Faces and Voices does on called Our Stories Have Power, that talks more in depth about the research behind this. Okay, so the next slide, in terms of solutions, we want to talk about that integration of treatment, also known as the no wrong door philosophy. So what does that look like in your settings? if you can tell me what the no wrong door philosophy looks like. I know that there's one program in New York City that I love that is a recovery set. It's a 5-story building, and there's primary care on one floor. There's a recovery center on another floor. There's an employment center on the next floor. There's a clinic, outpatient clinic on the next floor. And so you can get one-stop shopping, really. Like you go into this building and many of your needs can be met, or you get a referral. So that's, one of the ways that there's no wrong door, that everybody who walks into that building can get physical needs met. They can go to the mental health clinic. They can go to the recovery center. It's all in one building. How does it work there? That is the way Heritage is set up. Yay, one-stop shopping. Excellent. I'm glad to hear that. So some of the ways that we suggest, if you don't have fully integrated programs, is to do some cross-training for staff. So you have that one-stop shopping in a building, integrated programs, but if you can't do that, at least have people cross-trained. So in New York, we have mental health peer professionals and we have SUD peer professionals, and they should be cross-trained. You should be knowing what the other one is. And same thing on the clinical side. We have, our mental health providers, and then we have what we call KSACs, our SUD providers. And they're not often cross-trained at all. So that would be helpful if we could have people have information on both sides. Any other ways that you guys do this integrated treatment? I always wonder what's going on out there in the world. Okay, the next one is to value and include lived experience and peer support. Peers provide such a wealth of relatability and hope. They provide the living roadmap, show that recovery is possible. Peers who have successfully navigated both mental health and addiction systems provide a living roadmap that recovery is possible. And then the other thing that they do is they do some advocacy work, and they help humanize the data that you see and the diagnosis, right? And sometimes they actually challenge the provider's internal biases. And can advocate for a person's self-determination. Are peers pretty integrated into your systems there as well? Yes, that's a beautiful thing. Okay, awesome. Glad to hear that. Okay. Make space for storytelling. Oh, thank you, Elizabeth. I'm glad that you were able to be here. Yes, I'm sure you can grab the recording. You have a great day as well. Okay, so making space for storytelling, this is evidence-based. So when individuals with lived experience share their stories, it directly impacts how people with dual disorders are perceived. So there is a study that compared the different types of anti-stigma interventions. So, for example, the purely educational programming versus listening to personal testimonies of lived experience. And it concluded that that personal contact, whether it was in person or via recorded stories, it produced significantly larger and more sustainable improvements in public attitudes, in empathy, and in willingness to support individuals with the co-occurring disorders. So what Patty McCarthy, the CEO of Faces and Voices, says, you can't hate up close. That when we are fear-based and we don't know of anyone and we are fearful, we can develop animosity or resentment or hatred towards people that we don't understand. So how do your agencies or the communities that you're in, how do they make space for storytelling? We have something here in New York called community listening forums. And this is the coolest thing ever, because you get a whole bunch of mucky mucks in the room, policymakers, lawmakers, directors of agencies, CEOs. You get them all in the room and you put them on a panel. And you do not put microphones in front of them. You put the microphone across the room and you have people from the community stand up and tell their stories and make their asks and make their complaints. And the lawmakers and the policymakers and the CEOs listen. And they have been incredibly successful events. Faces and Voices of Recovery, it was the model for that. When I worked for Friends of Recovery in New York, we did that all over the state. Yeah, and so if you have guests come in, and it's a give and take, absolutely. I love the informal get-togethers like that so that questions can be asked, but I also love the formal things. That's why this picture of there's a woman on a stage, right? And she has an audience and she's telling her story to a captive audience. And so that's why I love the listening forums, because anyone from the community can get up on stage and tell their story. And so during your golf fundraiser, you have clients come. Oh yeah, that's beautiful. Yeah, the importance of funding the program coming right from the people that are being served. That's beautiful. I love that. Yeah, and so making this, even bringing it out wider, not just within our own agencies, but these community listening forums they're specific to a community, but they invite, all of the key stakeholders in the community to be listeners as well as participants to speak and tell their stories. And so we've had people with lived experience with substance use disorder, mental health, a lot of family members of people in recovery from one or the other or both, and a lot of family members of loss. So there are often parents who have lost a child to substance use disorder who make such a strong impact. These are some of the strongest advocates that I know, are these mama bears who've lost their cub. And they are ankle biters for sure, will come and tell their stories and make a huge impact on the people who may not have an experience in their own lives of what it is like to live with mental health issue or substance use disorder. So yes, there is some evidence behind all that. Okay, let's see, what do we got next? So adopting a trauma-informed perspective, that's a very important part of reducing stigma, because co-occurring disorders are a response often to significant trauma. And then stigma and discrimination are themselves traumatic. So we want to make a shift. So the shift in our thinking and the way that we speak about people from a problematic patient to a person surviving a set of difficult circumstances. Can you see we have so much more empathy towards someone when we frame it that way? So instead of asking what is wrong with you, yes, David, focus on the strengths, not the deficits. Absolutely. So instead of asking what is wrong with you, we ask what happened to you. Not just maybe externally with our mouths, but in our own minds. When someone is sitting before us and we have that thought, what is wrong with this person? You can just feel it in my tone, the way that I am speaking about it, as opposed to, wow, what happened to this person? That I come at it with so much more empathy and compassion when I ask the right questions. The survivor needs to choose when they are ready to share their story, and we need to be sensitive when asking people to share so that we are not re-victimizing you. Oh, thank you so much. Yes, in regards to human trafficking, but also I would say in terms of substance use disorder and mental health. And I think that this was a mistake that people in the movement made early on, that, we would find a poster child and, somebody who was doing well in the beginning of their recovery and, prop them up and give them speaking engagements. And sometimes that backfired for that person, that they really were not ready to share their story and they were kind of pushed out front too soon. And then I've had people who have told me, I was doing the Our Stories Have Power training one time in a room full of people, and one of them was a town councilman. And I'm asking people as we go around the room to, share your recovery status and blah, blah, blah. And I got a scathing email from him afterwards saying, you need to be careful with that, Teresa. I'm a town councilman and I am also a person in recovery, but I don't disclose that in a public setting because that's way too dangerous for me. And I have other people in my life who said I could lose my job if people knew that I was in recovery. And so people have to really feel comfortable and feel safe enough to share whatever their status is. Yes, thank you. You're reiterating exactly what I said, Amber. All stories need to feel comfortable for the person to share. Yes. Yeah, it could be really scary for people. Okay. So the other way that we reduce stigma is to actually advocate. And so advocacy comes in a number of different forms. It's big A advocacy and little a advocacy. So we want to advocate for policies that support mental health and substance use disorder recovery. And you can do that in a myriad of settings. So doing that in the workplace, in your community, in your state, and nationally. And so Faces and Voices of Recovery is an advocacy organization. In New York, we have Friends of Recovery New York. I don't know if Illinois has an equivalent. So the Recovery Community Organization that's guided, as we spoke in the beginning, by the recovery community. So people in recovery, advocates of the recovery movement, allies, family members. It's all represented on the national level by Faces and Voices. But in New York, it's Friends of Recovery New York is the statewide advocacy group, which actually is funded by our Office of Addiction Services and Supports. It wasn't always. It got some funding to do education. Yeah, it's advocacy, but we're calling it education. And then we have local chapters. So the Friends of Recovery New York has 30 plus local chapters in different places around the state where they're grassroots advocacy organizations. And of course, on the mental health side, we have NAMI and we have the Center for Rights and Recovery, because they just changed their name and I can't remember what it is. That's the full name. But we don't have one that is representing a dual diagnosis. It's still that siloed. We have substance use disorder advocacy groups and we have mental health recovery advocacy groups. Tell me about Illinois. What kind of advocacy do you have going on there? Do you have, we do it in the workplace on an individual basis, reframing the language in policies and, looking at our admission criteria. Yes, you have NAMI. That's good. But do you have, and NAMI is, I think, on the mental health side, but do you have anything on the addiction side that's an advocacy organization in Illinois? That would be something to take a look at, because Faces and Voices, CCHBC, Advisory Board at Heritage. Well, that's a beautiful thing. Thank you, David. Yeah. So there are some state, community, national, Illinois Association for Behavioral Health. Thank you, Kat. Lots of ways that we can do advocacy work. I would love to know. National Peer Recovery Alliance Illinois affiliate. All right. Beautiful. Okay. Thank you for that information. So there's lots of ways to get involved. So, I worked in the mental health in the substance use disorder field most of my career, and I had no idea that these advocacy organizations existed. And then when I watched the Anonymous people, and we actually formed one, the folks that decided to show that, so he had seen it somewhere else, and we made it a public viewing. And so people from the community came and watched the movie. And then after the movie, we sat around and said, well, wow, there's this whole national advocacy movement going on out there. What can we do? So we started meeting in the basement of the library once a month and eventually opened up a recovery center. It took a while and some funding, but actually opened up a recovery center, which is not a treatment program, but just a multiple pathways of recovery center. So, and then we've taken on multiple projects over the years. So it can start as small as a couple people sitting around having coffee, and what can we do to make our community more accepting of people with mental health and substance use disorders? How can we provide a safe place for them? I mean, so many different projects have come out of those grassroots movements. So you can do it in the workplace, in your community. You can join a state professional association. I see you said Illinois Association of Addiction Professionals. Thank you for that. And then, and there's NADAC, the National Association for Addiction Professionals, right? That's another national one besides Faces and Voices. Okay, so advocacy. Another solution is tailor your psychoeducation. So know who you're talking to. So move beyond that brain disease model and use a more balanced approach. This is evidence-based psychoeducation for dual diagnosis. Use the biopsychosocial model. So we definitely want to talk about the neurobiological components, genetic factors, vulnerability, chemical imbalances. We want to talk about psychological tools, so coping skills, trauma-informed care. We're going to talk about social supports, peer networks, stable housing. So these are all ways that we can educate people in treatment, but also the general public about what is needed to support someone who may have both. So the effect of all of that is that we're going to reduce blame, we're going to maximize people's self-agency, and then we're certainly providing hope for people in recovery. If you have any other examples of tailored psychoeducation, please feel free to share that with everybody. And then we'll talk about what individuals can do. Okay, so in terms of combating stigma on the individual level, and the first is and foremost, and that's the title of this presentation, let's change our language. So changing our language helps us feel less shameful, more empowered. Oh, you do the IDDT training. Excellent. Thank you, David. That's actually something I would think that's in here later on. That's a beautiful training. Okay, so this is the training that I've been plugging all along. It's the Our Stories Have Power training. It's a recovery community messaging training, but it's also a DEI training. They, as I mentioned earlier, Faces and Voices updated their mission to make sure that no one is left out. And so this is now a 9-hour training. That Our Stories Have Power training is 9 hours, and it's very interactive, and it's teaching people to advocate for themselves by changing their own internal dialogue around substance use disorder and mental health. And so this is that beautiful, powerful training called Our Stories Have Power. So in terms of clinical interventions, there are 3 things that the research showed. These are evidence-based clinical interventions to assist people in combating their own self-stigma. Internalized or self-stigma acts as a psychological barrier. It prevents people from engaging in care. Clinicians use specific evidence-based psychosocial therapies to help dual diagnosis individuals recouple their entity, recoup their identity from societal shame. And so we have the Ending Self-Stigma, or ESS core curriculum, acceptance and commitment therapy, and the modified cognitive behavioral therapy. I think that's the IDDT. So we'll just break them down. I'll just tell you a little bit about each one of these. So Ending Self-Stigma, the ESS core curriculum. Structured, multi-session cognitive behavioral intervention explicitly designed to help individuals with severe psychiatric conditions and co-occurring substance use challenges internalized stereotypes to replace self-blame with self-efficacy and develop healthy disclosure strategies. Let me see. So this is helping to resist the internalized stigma and its harmful effects. And these are practical, personalized strategies. This core curriculum was developed by, I don't know what all of this stands for, but it's in the, you can probably see just on the bottom in the little ticker tape on the bottom. It's VISN5 MIRECC and the University of Maryland School of Medicine. It's delivered over 9 weeks. It's usually 75 to 90-minute sessions, small groups, 4 to 8 participants. The sessions are combined in-class education, peer sharing, and then cognitive behavioral skill building. The core sessions focus on understanding stigma, defining public versus self-stigma, and then identifying how negative societal beliefs affect personal recovery. It also helps challenge negative beliefs using cognitive behavioral strategies to counter and reframe, strengths self-concept, and then, of course, identifying personal strengths and building resilience. There's a section on enhanced belonging and different strategies to increase connection with the community, family, and friends. And then a section on addressing discrimination and tools for safety and effectively responding to stigma in daily life. So this is an amazing curriculum. Yes, more information on the program. Thank you, Kat. Acceptance and commitment theory. Rather than fighting the thoughts associated with stigma, ACT teaches psychological flexibility. Individuals learn to accept their complex experiences without letting societal shame dictate their values or behaviors. And then there is, this is the IDDT, which is a modified cognitive behavioral therapy. So integrating CBT with motivational interviewing allows individuals to explore their ambivalence and substance use and psychiatric medication adherence simultaneously. So shifting the narrative from a moral failure to a personal health goal. All right, I'm glad you guys know about that stuff here. Just scrolling through the chat, see if there's anything else I need to. Oh, thank you, Kat. You're a really good little co-host here. I appreciate that. Okay. Next slide, we are on slide number 52, so we have 10 more slides. How are we doing on time?
Maybe just a few more minutes, Teresa, if possible. That 1:30 hour sneaking up on us.
Okay, all right, we have 10 more slides to go, but some of them are pretty short things. Okay, so combating self-stigma is also peer support. Peers are hope dealers, right? So I'll come back to this if I have time. I have a story to tell you about that, but I want to get through the next 9 slides, and then I'll come back to the hope dealer story. So in communities, we want to make sure that we are combating stigma in housing programs, recovery programs, employment, colleges, high schools, and all by using an intersectionality lens. So recognizing that social determinants and there are compounding identities, and we talked about this a little bit before, but always to keep in mind that the person is not just dealing with a substance use disorder or a mental health issue if they have any of these compounding identities. So race, physical ability status, sexual orientation and criminal justice system involvement, socioeconomic status, gender identity, et cetera, et cetera. So I'm just going to read you this one about systemic bias, right? A person of color with co-occurring disorders may be met with a punitive response, incarceration rather than a clinical response, hospitalization or rehab compared to a white counterpart with the same symptoms. And I've actually seen this happen. I have one of my former colleagues was arrested with a friend, and they were both arrested for the same thing. He was white, his friend was black, his friend went to jail, he was sent to treatment. This is real. This absolutely happens. And then also understanding that sometimes where we live, our geography, will prevent us from being able to access resources. So high quality integrated care is often expensive or unavailable in rural and underserved urban areas. So that makes geography a significant factor in systemic discrimination. Oh, thank you for that, Amber. Okay, so we are at the summary. So this is good. Let me look at my clock here. Oh dear, here we go. So to wrap things up, I'm just going to do a quick summary and then ask you to make a commitment to some action. So here we are. We want you to listen without judgment. When someone shares their story, meet them with empathy, not assumptions. Use person-first language. Say a person living with addiction rather than an addict. Educate ourselves and others. So learn about the experiences of marginalized groups and barriers they face in accessing care, and challenge stereotypes. So speak up when you hear stigma in conversations in the media or in the workplace. So those are some of the summary actions that we can take. Okay, so my question to you is, what will you do? What will you do? And you could write it out as a SMART goal if you like. We have and continue to incorporate survivor-centered trauma-informed language in our presentation and language regarding human trafficking. Excellent, Wendy. I'm so glad to hear that. So if you found anything in this presentation new, or an aha moment, or something that reinforced something that you like, yes, I need to do that, I would ask you to throw that in the chat. Thank you so much for all the resources, Kat. You are invaluable here. Commit to educating myself and others moving forward with the guests that come into the living room. Yay! Thank you. And so I'll ask you if you have any questions or comments. Feel free to unmute yourself, put whatever you like in the chat. If you have an aha moment, to share that, or maybe a takeaway. What was the biggest takeaway from this presentation today that you can leave here saying, oh, this is what and I do this for a reason, not just to give me feedback that I know I'm doing my job, but to reinforce it for you and everybody else in the room. What was the thing that you went, oh, yeah, that, I got to remember that. Oh, this is the thing that I'm going to either commit to do or reinforce with my team. And Faces and Voices of Recovery website. This is my contact information is Teresa at teresamnor.com. I own my own business, Balance Recovery Consultation and Tai Chi for Recovery, but I'm also an independent contractor with Faces and Voices of Recovery. So you can contact Faces and Voices at their website. You can contact me at my website or my email. Yes, love. I'll come do some for you, Kat. Well, let's talk. And then here is the list of all the myriad of studies, the references and sources for all of the information in this presentation. So I'm going to come off here and see if there are any questions, comments, get you all out of here on time.
While folks are putting some of their final thoughts or questions in the chat, Teresa, thank you again so much for your time today. We truly appreciated your insight, your expertise, your engagement. You've been truly fabulous to learn from. And to all of our participants, thank you for spending part of your day with us as well. We really hope that this training session was valuable and meaningful for each of you. Later this afternoon, you will receive a training evaluation, so we strongly welcome your feedback and thoughts so we can continue improving our future trainings. And then if you'd like to be involved in McLean County Recovery-Oriented Systems of Care, our local recovery coalition in McLean County, or if you'd like to just know a little bit more about the work that we're doing, I'm going to go ahead and put in the chat our email address. We'd love to be in touch with you. If we're not already kind of involved and in touch, we'd love to be able to get you connected. So thank you everyone for your time today. We hope you have a wonderful rest of your day. I don't see any other questions, Teresa, so I think we are all squared away.
All right. Well, thank you, everybody. I appreciated all the input. That certainly makes my job easier when you're, interactive. So have a great day, everybody.
Take care.